everyone, OT Lifehacker here. What should you know before going into your patient's room to do occupational therapy in the acute care setting? Now, it is very important before you go into the patient's room that you know some key things about them. And how do you find that information? You can go into do a chart review. So you can look at the documentation that is provided about them on the electronic medical records or wherever in your facilities you would find it. And this is very likely for all settings. If it's not the case in your setting, please do share below, because I've never really heard of that, of not having a chart review before you go into the patient's room. But people do things differently, so they may find what works for them and get into their own routine. In acute care, what I've learned from my supervisor, I will be sharing with you today. So that is my Saturday treat for you all. Woohoo! And what I gathered is that you do the chart review, but also supplement the data gathered from nurses, and the other staff involved with this patient. And so that's an interdisciplinary team. You can talk to the speech therapy or the physical therapy that are working with them, and if needed, maybe you may even need to talk to the physician who is working with them, or the residents who are working with them, whoever you need to talk to get your information. Do so, because again, remember that you are advocating for the client. If you are unsure about anything or need to clarify, go to the person that you need to talk to. And many times it is the nurses that we talk to who have all information to give us. Nurses are phenomenal in bridging that communication for us between the other parties, because they are always there with the patients. So thank you all. And also, the other important reason why you should check in with someone who is on the case for this patient before going into the patient's room, and even possibly before you dive into the chart review, take a look around that floor that you are going to be seeing the patients on. Look in their rooms, see if they are eating breakfast, if they're it's being seen by someone else, if there are any notes on the side of their room that maybe it says like in isolation or something, because that has happened for us before where there are no indications for isolation. We go to the patient's room and it says isolation, so we had to change our plans. And you want to check out the rooms and see if the patient's available before you necessarily do the chart review, because if you do the chart review, then go to the patient or talk to a nurse and they tell you that, oh, the patient cannot be seen right now, they're getting a CT scan, or they are being transferred somewhere else, they're being discharged, they're not feeling well, they're nauseous, the doctor just recently put in bed rest orders, or anything. That things can change rapidly. Oh wow, did I actually just snap? Not really, but let me just like I can't really snap, guys, but that's the best I can do. Just listen very carefully to my little sound. Anyways, there's a lot of things that change in the acute care, and that's one of the things that is so I mean, it's hard for a lot of people to be working with the changes, but that requires a lot of problem solving and creativity on your part to just think on your feet. What are you going to do? Maybe change up your treatment plan, or probably have to change up your treatment plan, or go see them another time. Maybe even if someone else is in the room, ask if you can join in with someone else, meaning like another healthcare professional. If appropriate, ask if maybe you can join in with them as they're working with the patient. And the chart review, you'll first want to see how much they weigh. And the reason for this, knowing how much they weigh, is because if you're going to use durable medical equipment such as a cane, a walker, wheelchair, you'll want to know their weight, because the durable medical equipment, say for example a walker, might say maximum weight is 200 pounds. So if the patient weighs 300 pounds or something, then it wouldn't be safe for them to use that walker. You would have to find a walker that would fit for their weight. And again, that's kind of like a sort of to help smoothen the process. So again, before you go to the room and realize, oh man, this patient's bigger than I thought, I don't know if they'll fit in this walker, and maybe you realize that as you're already working with the patient, carrying them, then it gets more complicated than it needed to be. If you check the weight first, it'll be very helpful. And then hemoglobin, my supervisor told me to check the hemoglobin, so the blood, to check that, because if it's low, then you will need to consider that, okay, be very careful when working with this patient when raising them from lying down to sitting at the edge of bed. Go slowly and monitor if they have nausea or if they feel dizzy or any signs that they need to rest. Lie back down. And I also learned, so we actually did this for a patient who had gotten up and they were feeling very dizzy. They had lay back down in the bed, and the supervisor put them into the Trendelenburg gait position. So he had the person's head lower than their feet, which the idea behind that is to get the blood flowing to the head, but there's not significant or conclusive research on that. He had told me that the other thing is to make pain happen so that the person's blood flow is better. I personally will need to research all of this more to see what evidence is out there in regards to orthostatic hypotension. This would be very good information for you to know as well. So maybe you might want to take do a little research before you go into the field, so that you know how to go into the setting, so that you know, have some tools under your belt for how to handle orthostatic hypotension. And also with the hemoglobin, if the patient, and this is for our facilities, if the patient's hemoglobin is below 7, then you wouldn't work with them because of the safety risk. However, I was told that if they are Jehovah's Witness, or if there are certain circumstances in which these are exceptions, you can work with them even if it's lower, because they're not going to get have blood transfusions or anything like that. Then you can work with, you have to know this in your facilities. You have to ask, get the policies around that. And also take note if the hemoglobin declines over time, because that can be also an indication that, this is something to watch out for. when working with them, that they might feel, again, lightheaded or feel nauseated. And then you also want to look out for precautions. This is very important because when you are doing ADLs, activities of daily living with the patients, which is pretty much what you'll do with all patients in acute care, you'll be doing functional mobility, such as walking them and having them walk to and from the bathroom, transfer to a chair, so sitting from the edge of the bed to sitting at a chair or walking to a chair. Having them do their grooming activities, washing their face, brushing their teeth, brushing their hair, and also bathing, toileting, showering, and dressing, upper and lower body dressing, and also being able to put on any orthoses, which are protective equipment that can be wrapped around the arm, or some sort of protection or stabilizer that is external, and you have the patient wear it. They can have that, or a brace, like a back brace, or other things that they have to wear or put on. And there may also be a weight-bearing precautions, such as if the person has had a total hip arthroplasty or some sort of hip surgery. And again, also hip precautions, back, spinal, cervical, meaning like the neck precautions. So you have to be on the lookout for that. Can the patient bend over past 90 or past a certain degree? Can they twist? Can they pull? Or is that pulling out? Can they pull? Can they push? Can they lift things? How much can they lift? Stuff like that. Or even about for cardiovascular stuff, knowing how much activity level they can do, to what level to get the heart rate up to, or so there's a lot of things that you have to consider when you're doing your ADLs with them. And in order to consider this stuff, you need to do the chart review. So other things you need to know is, what is a person's diagnosis? What is their primary complaint? But also know their secondary complaints, because oftentimes that can take the precedence for treatment. So that can be the pressing problem in the treatment at that time. Say for example, the person may have, they may have they may have just had spine surgery, but then they also have pain from their hand, or they're starting to feel some sort of like cognitive thing or something that is hindering their activities, ability to perform activities. So you have to look at all of those factors, because I have not seen any patient who has had only one problem. Then again, it's mostly older adults, so there's typically comorbidities. Typically, the person has more conditions than one. And then, who is the nurse that is working with them? Because that is your route of communication. You always need to check in with the nurse to see if you can see that patient. Many times, the supervisor and we would go over to the nurse and find out that we cannot see the patient right now. They are being taken for a CAT scan, or they are being discharged, or they're being moved to another room, or their conditions changed, and so they are being put back on bed rest, or a lot of different circumstances. So you need to have that communication open. And you'll also want to check in with the physical therapy, speech therapy, or other rehabilitative services that are working with them, because they may have just seen the patient, or they may have new updates to give you about the patient and how they did in therapy, so that you can be pre-warned. However, it's interesting because not always you can't expect to rely on that. Things again will rapidly change, because yesterday we had seen a patient who we actually saw 2 patients, and the therapist who was physical therapy saw those 2 patients too at a different time, and we had told that therapist how one patient did and how the other patient did. One did really had been in good very able to carry out the task, and the other had more challenges. And the funny thing was that the physical therapist had the same comments, but it was reversed. So the patient for us who had more challenges was actually better able to do the activities with the physical therapist, and the one who had for us less challenges and was better able to do activities with us had more challenges for the physical therapist. And again, you have to consider that it was different times of the day, different people had seen them, they had different treatments throughout the day, so there's a lot of factors. And then you also want to look at any labs that they had done. Again, that's where the hemoglobin, checking for their blood levels, and any x-rays they did, CT scans, MRI, any assessments they had, such as like the stroke assessment, what's their level of functioning currently. You can tell some of that by looking at the assessments and the lab results. And who has the doctor consulted with is important, because the admitting doctor may have consulted with other doctors or other specialties. Say for example, you find out that the patient the admitting doctor finds out that they may have cancer, so admit them into oncology, and you'll probably have a radiologist involved for doing the x-rays and all of that, and probably